So next is bariatric surgery. It's V2. So first of all, they mentioned the classification of BMI, how BMI is calculated. So it's calculated by weight in kilogram divided by meter square. So just to memorize this, the classification, BMI classification is equal to underweight less than 18.5 kilogram per meter square, healthy weight more than 18.5 to 24.9, overweight 25 to 29.9 kilogram per meter square, obesity 1 30 to 34.9 kilogram per meter square, obesity 2 35 to 39.9 kilogram per meter square, and obesity 3 more than 40. So why should surgery be offered for the treatment of morbid obesity? So obesity has caused on country and its associated comorbidities, and the obese people have reduced life expectancy due to cancer-related deaths, coronary artery disease, type 2 diabetes, fatty liver, and metabolic syndromes. And it has now been recognized that bariatric surgery has profound metabolic benefits, in particular with patients with type 2 diabetes mellitus, metabolic syndrome like type 2 diabetes mellitus, hypertension, obstructive sleep apnea, and polycystic ovarian syndrome. Which patients are eligible for bariatric surgery on the NHS? So anyone without any medical condition with BMI more than 40 or BMI more than 35 with metabolic disorder like type 2 diabetes mellitus, obstructive sleep apnea, hypertension, osteoarthritis, and all appropriate non-surgical measure has been done and has tried and not achieved and or not maintained an adequate and beneficial weight loss. The patient must be receiving or will receive intensive management in a tier 3 service, and they must be fit for surgery and anesthesia, and patient commits to need long-term follow-up almost 2 years with the bariatric services. And immediate preparative preparation includes liver shrinkage diet for 2 weeks, stopping smoking, treatment of obstructive sleep apnea, and adequate perioperative diabetes control. Next is which bariatric surgical procedures are available for the treatment of obesity. There are 3: laparoscopic gastric band, laparoscopic sleeve gastrectomy, and laparoscopic Roux-en-Y gastric bypass. So how does gastric band work? So the band is placed around the upper part of the stomach with the creation of 20 ml volume pouch above it, and fundus is sutured over the band to create an anterior tunnel to prevent the slippage, and an access port is fixed to the rectus sheath for easy access and inflation, and the band is adjusted by fluid inflation or deflation through the access port. And studies have shown that the average loss of excess body weight at 5 years with laparoscopic gastric band is 48%. How does sleeve gastrectomy work? So body and the fundus of the stomach are excised vertically using a linear stapler to create a narrow gastric tube along the lesser curve with a capacity of approximately 150 to 200 ml. And then linear stapling device begins deviation 3 to 6 cm proximal to the pylorus and moves upwards just lateral to the angle of His. The average loss of excess body weight at 5 years is 53%. How does a Roux-en-Y bypass procedure work? This is the most effective surgical procedure with both weight loss and metabolic benefits, and a small 20 ml gastric pouch no longer than 5-6 cm formed by the division of the third gastric body and fundus, and distal jejunal limb with anastomosis to the pouch. Approximately 100 to 150 cm of distal jejunal limb is then bypassed before the proximal biliary jejunal limb is anastomosed to the distal jejunal limb. The biliary limb length is not measured but kept short in order to reduce the malabsorption of vitamins and minerals. The average loss of excess body weight at 5 years with laparoscopic Roux-en-Y gastric bypass is 63%. So, what are the advantages and disadvantages of each bariatric surgical procedures? So, laparoscopic gastric band advantage is safe, less than 0.1% mortality. It's reversible, adjustable, and does not disrupt the normal anatomy and does not prevent further bariatric surgery. Disadvantages: complications, slippage, prolapse, infarction, ischemia of the stomach. Regular follow-up needed in order to achieve good results. 10% of the patient develop complication within 6-10 years, and as many will request more of their band due to these complications within the same time period. The laparoscopic sleeve gastrectomy advantage is safe and very effective bariatric procedure with the operative mortality 0.2%. No adjustment required. Single one-off procedure, does not preclude further bariatric surgery. Disadvantages: stapler line leakage, tubal stenosis, exacerbation of acid reflux, potential weight regain, and required nutritional supplements like calcium, vitamin D, folic acid, iron, and vitamin B12, and irreversible surgery. Laparoscopic Roux-en-Y gastric bypass, single one-off procedure, dramatic metabolic benefits leading to improved glycemic control and remission of the diabetes, improvement in hypertension and hypercholesterolemia. Disadvantage: operative mortality is 0.5%, anastomotic leak, internal herniation, gastrojejunal stenosis, and marginal ulceration. Require lifelong routine metabolic and nutritional monitoring. Irreversible surgery. How would you decide which bariatric surgery is most suitable for the obese patient? There are no clear recommendation. Many factors must be considered. MDT discussion. Patient decision will be the paramount importance, and the patient should meet with the patient support groups. And it also depends on the degree of obesity and the associated comorbidity risks of surgery and patient compliance and eating habit, and there is a risk to benefit ratio for each operation. Due to the high incidence of gallstones among of the obese population, would you routinely perform a cholecystectomy at the same time as a bariatric operation? There is controversial area. So at the minute in UK, there is no recommendation for this in the UK. So if someone needs ERCP after laparoscopic gastric bypass, it will alter the anatomy. And similarly, a complication of cholecystectomy in a patient who has undergone simultaneous gastric bypass may be catastrophic due to catabolic state these patients are in. Gastric burning, including the implantation of foreign body, and hence a cholecystectomy would increase the risk of infection. Finally, a prophylactic cholecystectomy is not included in the current funding tariff for bariatric surgery, nor will there be a direct cost to the hospital itself. Thank you.